Hello, I'm Dr. Barry Singer, the director of the MS Center for Innovations in Care at Missouri Baptist Medical Center in St. Louis. Welcome to this educational activity on multiple sclerosis, focusing on updates from the 2018 ECTRIMS meeting in Berlin. A large number of platform presentations and posters on approved and emerging disease-modifying therapies were presented at this meeting. So let's get started with a brief summary of new data related to available injectable therapies for the treatment of relapsing remitting MS. We will begin this section by highlighting some recent updates on the efficacy and safety of various interferon beta preparations. First, 15-year follow-up data from the BENEFIT study continue to support a sustained benefit of early intervention with interferon beta 1b and reducing the risk of relapse and conversion to clinically definite MS. Cortell's presented a platform presentation that looked at the BENEFIT 11 data, and interestingly, 11 years out, we found that there was a correlation with low vitamin D and cognitive impairment 11 years later, as well as smoking increased the risk of cognitive impairment 11 years later in clinically isolated syndrome patients entering the trial. In addition, Hellwig and colleagues presented data on the prevalence of pregnancy and infant outcomes in interferon beta exposed pregnant women with MS from European Interferon Beta Pregnancy Registry and Nordic Health Registries. In this regard, the European Interferon Beta Pregnancy Registry showed no evidence that interferon beta exposure before conception and/or during pregnancy adversely affected pregnancy or infant outcomes, which was consistent with data collected from the Nordic registries. We also saw a number of updates related to Pegylated interferon beta 1a. For example, a propensity score matching analysis using data from the phase 3 advanced and confirmed trials showed significantly lower annualized relapse rates and 12-week confirmed disability worsening with PEG interferon beta 1a compared with Glatiramer acetate 20 milligrams once daily. In addition, the percentage of patients with overall no evidence of disease activity, or NEDA, or magnetic resonance imaging NEDA over 2 years was significantly higher with PEG interferon beta 1a than with GA. Moreover, a post-hoc analysis of the ADVANCE trial presented by Arnold and colleagues showed that both newly diagnosed and non-newly diagnosed patients who received continuous PEG interferon beta 1a every 2 weeks were less likely than newly diagnosed or non-newly diagnosed patients who received treatment delayed by 1 year to develop chronic black holes from new or enlarging T2-weighted or gadolinium-enhancing lesions. These were consistent with the overall patient population. In addition, newly diagnosed or non-newly diagnosed patients who did not develop black holes from gadolinium lesions at baseline, week 24, or week 48, or new or enlarging T2 lesions at week 24 or 48 during the ADVANCE had less clinical disease activity over 96 weeks. A lower risk of developing black holes from acute magnetic resonance imaging lesions with PEG interferon beta 1a suggests the therapy's potential to provide treatment benefits to patients with relapsing MS, including newly diagnosed patients, by reducing long-term disability through prevention of irreversible tissue damage. Lastly, we also saw data on 25 years of continuous treatment of multiple sclerosis with Glatiramer acetate. In this regard, results of the U.S. open-label extension study continue to demonstrate the long-term safety of this agent. Let's now turn our attention to new data on approved oral disease-modifying therapies for the treatment of multiple sclerosis that were presented at the 34th Congress of ECTRIMS. I'll start with key updates related to the effects of Teriflunomide on brain atrophy measurements and other MRI metrics in patients with relapsing MS. In the TOPIC study, Teriflunomide significantly reduced the risk of conversion to clinically definite MS versus placebo in patients with the first clinical episode suggestive of MS. At the 34th Congress of ECTRIMS in Berlin, Zvadanoff and colleagues presented data on the effect of Teriflunomide on changes in whole brain volume in patients who were enrolled in this study. The results of this analysis showed that at months 6, 12, 18, and 24, teriflunomide 14 milligrams significantly reduced brain volume loss, 87%, 29%, 36%, and 43% respectively when compared to placebo. These observed reductions in brain volume loss augment the demonstrated benefit of teriflunomide in preventing relapse and disease progression in patients with the first clinical episode suggestive of MS. Springer and colleagues also presented data from the TEMSO trial, which examined the effect of teriflunomide on diffuse brain tissue damage. The results of this analysis showed teriflunomide 14 milligrams produced statistically significant treatment effects on the percent brain volume change at years 1 and 2 compared to placebo. Importantly, most of the treatment effect of teriflunomide 14 milligrams on percent brain volume change was independent of its effects on relapses and focal lesions. These findings suggest the effect of teriflunomide on brain volume loss may be due to reducing diffuse neurodegeneration rather than secondary to reduced focal inflammation. Data on the effect of teriflunomide on unique active lesions was also presented at the 2018 ECTRIMS meeting. The results of a post-hoc analysis of the Phase 2 trial and the Phase 3 TEMSO and TOPIC trials presented by Miller and colleagues showed using all time points, week 6 up to 108, teriflunomide 14 milligrams significantly reduced unique active lesions compared to placebo. These observed reductions in unique active lesions may represent an important indicator of disease activity in MS patients and provides a means to monitor disease activity and treatment response. Coming and colleagues also presented data from a pooled analysis of the Phase 2 study and the Phase 3 TEMSO, TOWER, and TENIR studies, which looked at the effect of teriflunomide in subgroups defined by prior treatment. The results of this analysis showed teriflunomide 14 milligrams significantly reduced the risk of relapse compared with placebo, irrespective of prior treatment status. Although patients with prior DMT use had a higher level of baseline disease activity versus patients with no prior DMT use, teriflunomide demonstrated similar efficacy in these subgroups. In addition, this analysis showed most adverse events were mild to moderate in severity, were generally similar across treatment groups, though the rates of diarrhea were lower among patients who had not received a prior DMT. Long-term, up to 12 years, efficacy and safety outcomes in teriflunomide 14 milligrams were also presented at the 2018 ECTRIMS meeting. In a pooled analysis of patients receiving teriflunomide 14 milligrams from the Phase 2 study and the Phase 3 TEMSO, TOWER, and TENIR clinical trials and their extensions, Friedman and colleagues showed that the overall annualized relapse rate and yearly annualized relapse rates were low and stable, and the yearly proportions of patients free from relapse were high and stable. In addition, disability status, as measured by EDSS, remained stable through year 12. Importantly, no new safety signals were reported in these clinical trials. Most adverse events were mild to moderate in severity. Now, let's shift our attention to some of the recently presented data on dimethyl fumarate. Dimethyl fumarate demonstrated strong efficacy and favorable benefit-risk profile in patients with relapsing remitting MS in the Phase 3 DEFINE and CONFIRM trials, as well as associated ongoing extension study ENDORSE. At the 34th Congress of ECTRIMS in Berlin, an integrated analysis of DEFINE, CONFIRM, and ENDORSE demonstrated the clinical benefits of DMF on relapse activity and disability progression in newly diagnosed patients are maintained over 9 years. In patients continuously treated with dimethyl fumarate, annualized relapse rate remained low for 9 years. Patients who were initially treated with placebo saw a decrease in annualized relapse rate after initiating dimethyl fumarate in ENDORSE. In addition, EDSS scores remained stable over 9 years, with greater than 90% maintaining walking abilities after 9 years of treatment, as measured by an EDSS score of less than 4. Moreover, in patients for whom walking abilities were not impacted at baseline, the majority were estimated to have maintained these walking abilities, 97% for patients treated with DMF continuously, 93% for patients who received placebo prior to DMF. Another integrated analysis of the phase 2b, define, confirm, and endorse studies showed an increased incidence of serious or opportunistic infections was not observed in DMF-treated patients with lymphopenia who were followed for up to 11 years, aside from the very rare cases of PML. In addition, absolute lymphocyte counts increased following DMF discontinuation for the majority of patients in this analysis. Moreover, early drops in absolute lymphocyte counts, less than 0.8, in the first 6 months of DMF treatment were generally not predictive of the rate of ALC reconstitution after DMF discontinuation. The rate of reconstitution after DMF discontinuation due to lymphopenia was similar for all patients, regardless of absolute lymphocyte count at the time of discontinuation. Additional data from a phase 4 retrospective chart abstraction study of patients with relapsing remitting MS who had been exposed to DMF under routine clinical care for at least 3 months and up to 2 years suggested that among a majority of patients who experienced lymphopenia during DMF treatment, meaningful lymphocyte reconstitution occurs within 3 months of treatment discontinuation. However, assessment of lymphocyte reconstitution is influenced by visit schedule and may be evident early in patients with more frequent assessments. In addition, patients who discontinue DMF with severe lymphopenia, absolute lymphocyte count less than 0.5, tend to reconstitute at a similar rate as patients without severe lymphopenia. The mean ALC for these cohorts near the lower limit of normal after 18 months versus 2 months after discontinuation, respectively, by mixed effects modeling. These data on the dynamics of lymphocyte reconstitution may be informative for clinicians who are managing patients with DMF who develop lymphopenia during DMF treatment. Giles and colleagues also presented interim results from the ESTEEM study. ESTEEM is an ongoing 5-year multinational prospective non-interventional study evaluating the long-term safety and effectiveness of DMF in patients treated in clinical practice. Thus far, data from the study has shown that real-world patients treated with DMF had significantly lower annualized relapse rate at 24 months after DMF initiation compared with the prior 12 months. In addition, positive effect on patient-reported outcomes, including psychological impact of MS, fatigue, everyday functioning, and work productivity, was reported for patients while on DMF treatment. In this analysis, the clinical benefits and discontinuation rates observed in newly diagnosed early MS and interferon or GA switch patients were consistently with the findings in the overall ESTEEM population. These real-world data are consistent with data from the pivotal phase 3 clinical studies and support DMF as an effective treatment option for patients with relapsing MS, including those who are newly diagnosed or early in their disease course, or those switching from interferon or Glatiramer acetate. Let's turn our focus to some new key data presented on Fingolimod. LONGTERMS is an open-label, single-arm extension study evaluating the long-term safety, tolerability, and efficacy of Fingolimod in patients with relapsing remitting MS who completed the phase 2, 3, or 3b Fingolimod trials. At the 34th ECTRIMS Congress, Kapos and his colleagues presented data on the long-term effect of Fingolimod 0.5 milligrams on disease activity and safety in patients with relapsing remitting MS who received continuous Fingolimod treatment for at least 5 years, up to 10 years, in long terms. The results of this analysis showed patients treated with Fingolimod 0.5 milligrams for at least 5 years maintained low disease activity. However, the influence of selective attrition could not be excluded. In addition, the reported safety was consistent with the known profile of Fingolimod without the emergence of new safety concerns. In addition, the top-line results of the CESS trial were announced at the time of the 34th Congress at ECTRIMS. ASSESS is a phase 3b study which evaluated the efficacy and safety of oral once-daily Fingolimod 0.5 milligrams and 0.25 milligrams versus once-daily subcutaneous injections of Glatiramer acetate 20 milligrams in patients with relapsing remitting MS. Initial report indicate that the data showed that Fingolimod 0.5 milligrams significantly reduced annualized relapse rate by 41% compared to Glatiramer acetate. Further, initial findings show adults taking Fingolimod 0.25 milligrams achieves a numerical risk reduction in relapses compared to the comparator, but not statistically significant. In addition, the safety of Fingolimod observed and assessed across both doses was consistent with the known safety profile of the drug, with overall more discontinuations due to adverse events and unsatisfactory treatment effects reported in the Glatiramer acetate group. We look forward to this data being formally presented in 2019. One of the reassuring points when we look at the extension studies of these three oral disease-modifying therapies, Fingolimod, Teriflunomide, and Dimethyl Fumarate, is we see the annualized relapse rate staying very level. In addition, EDSS scores stay very stable. So this is quite reassuring in prescribing these disease-modifying therapy agents long-term. In addition, no new safety signals were seen, which is also a very important aspect of having extension studies of the pivotal clinical trials. Data on approved monoclonal antibodies also continues to accumulate, as evidenced by the number of abstracts presented at the 34th Congress of ECTRIMS in Berlin. Let's start this section by discussing some of the key data on natalizumab that was presented, beginning with data from the TOP study. TOP began more than 10 years ago and is the largest ongoing real-world study of relapsing remitting MS patients treated with natalizumab. The results of an interim analysis of this study were presented at ECTRIMS 2018 and demonstrate natalizumab's consistent safety and effectiveness over 10 years. For example, significant annualized relapse rate reduction were observed regardless of baseline disease activity or the number of prior treatments. In addition, natalizumab provided long-term control of relapsing remitting MS disease activity, as shown by the stability of relapse rates and EDSS scores over the study duration. The estimated cumulative probability of disability improvement exceeded 30%, while the estimated probability of disability worsening remained less than 30%. For up to 10 years of natalizumab treatment, safety findings were consistent with the current safety profile of natalizumab, and no new safety concerns were identified. Lastly, the incidence of opportunistic infections, PML, and malignancy were low. At the 34th Congress of ECTRIMS, Mason and colleagues presented data on longitudinal changes in anti-JCV virus antibody index in patients treated with natalizumab or placebo over 2 years in the ASCEND study. The results of this analysis of anti-JCV virus antibody index stability in a randomized placebo-controlled trial provides robust evidence that natalizumab is not associated with changes in index over 2 years of treatment. In addition, longitudinal anti-JCV virus antibody index changes during the study were similar in the natalizumab and placebo-treated populations. These findings confirm and extend the results from clinical trial and real-world settings showing low rates of conversion from low to high index thresholds in patients treated with natalizumab. The cumulative probability of conversion from anti-JCV virus antibody index less than or equal to 0.9 to greater than 1.5 without subsequent reversion over 108 weeks was low overall and similar in patients who received natalizumab or placebo. The variability seen in the likelihood of anti-JCV virus antibody index changing from less than or equal to 0.9 to greater than 0.9 is consistent with previous reports of fluctuation around index thresholds. As investigators were blinded to anti-JCV virus antibody test results during the study, natalizumab discontinuation and study withdrawal were not influenced by serostatus or index value, eliminating bias in this population. The stability of the anti-JCV virus index in patients who received natalizumab or placebo further supports the use of the index for clinical decision-making and individualized patient management to stratify the risk of natalizumab-associated PML. In addition, Giovannoni and colleagues presented data showing the overall incidence of natalizumab-associated PML has been stable since mid-2016, which has coincided with the introduction of new PML risk estimates, suggesting that the risk stratification factors are being incorporated into clinical practice and may continue to influence future PML incidence. In addition, the results of this analysis extend previous work showing the greatest increase in PML incidence occurred between 2009 and 2013. The greater relative increase in patients in higher exposure epochs from December 2011 to December 2013 than in later time periods may have been a key contributor to the increasing PML incidence during that time. Over the past 4 years, the number of patients treated for longer durations has increased, while PML incidence in higher exposure epochs have decreased. The decrease in PML incidence within each exposure epoch over time suggests that other risk factors, anti-JCV virus, antibodies, and prior immunosuppressive use, may be decreasing in the natalizumab-treated population, which is consistent with physicians' utilization of risk stratification in their clinical practices. Taken together, these results underscore the importance of PML risk stratification as part of patient management guidelines for natalizumab. Moving on to alemtuzumab. In the RRMS 1 and 2 studies, 2 courses of alemtuzumab demonstrated significantly greater improvements on clinical and MRI outcomes versus subcutaneous interferon beta-1a over 2 years in patients with active relapsing remitting MS who were treatment naive and had inadequate response to prior therapy, respectively. Patients completing at least 48 months of RRMS extension study could enroll in Topaz, a 5-year phase 3b/4 study to further evaluate the durable efficacy and long-term safety of alemtuzumab. Of the 376 patients who entered RRMS 1, 290 completed year 2 of Topaz, year 8 after initiating alemtuzumab. Alemtuzumab demonstrated durable clinical efficacy in patients with active relapsing remitting MS who were treatment naive. 56% of patients received neither additional courses of alemtuzumab nor another DMT through year 8. The annualized relapse rate at year 8 was 0.14. 88% were relapse-free in year 8. 78% of patients had stable or improved EDSS scores from course study baseline through year 8. 71% of patients were free from 6-month confirmed disability worsening, and 41% achieved 6-month confirmed disability improvement through year 8. In year 8, 60% of patients achieved NIDA. 67% were free from MRI disease activity. The median percent cumulative brain volume loss from baseline through year 8 was minus 1.83%. The reduction in brain volume loss was 0.22% or less annually from years 3 through 8. The safety profile in year 8 was consistent with the previous years. The incidence of adverse events, infections, and thyroid adverse events continued to decline through year 8. Now let's look at data from Topaz from the cohort of patients who were treated with subcutaneous interferon beta-1a over 2 years of the RRMS 1 course study. Of 139 patients initiating alemtuzumab in the extension, 117 completed year 2 of Topaz, year 6 after initiating alemtuzumab. Alemtuzumab demonstrated durable clinical efficacy over 6 years in patients with active relapsing remitting MS who were previously treated with subcutaneous interferon beta-1a during RRMS 1. 67% received neither additional courses of alemtuzumab nor another DMT. At year 6, the annualized relapse rate was 0.19, and 70% of patients had stable or improved EDSS scores from RRMS 1 baseline. After initiating alemtuzumab, 69% were free from 6-month confirmed disability worsening, and 28% had 6-month confirmed disability improvement. At year 6, 62% were free of MRI disease activity, 82% were free of new gadolinium-enhancing lesions, and 62% were free of new or enlarging T2 hyperintense lesions. The median percent cumulative brain volume loss from RRMS 1 baseline was negative 1.99% over 8 total study years. Minus 1.49% occurred over years 0 through 2 with sub-Q interferon beta-1a, and negative 0.23% occurred over 6 years with alemtuzumab. Safety was consistent with alemtuzumab arm of the core and extension studies. Now let's turn our attention to data from TOPAZ from the CARE-MS2 cohort. Of the 435 patients who received alemtuzumab in CARE-MS2, 300 completed year 2 of TOPAZ, year 8 after initiating alemtuzumab. 44% received neither additional courses of alemtuzumab nor another DMT through year 8. Annualized relapse rate at year 8 was 0.18. 85% were relapse-free in year 8. 70% of patients had stable or improved EDSS scores from core study baseline through year 8. 64% of patients were free from 6-month confirmed disability worsening, and 47% achieved 6-month confirmed disability improvement through year 8. In year 8, 58% of patients achieved NIDA. 70% were free of MRI disease activity. 89% were free of new gadolinium-enhancing lesions, and 70% were free of new and enlarging T2 hyperintense lesions. Median percent cumulative brain volume loss from baseline through year 8 was only negative 1.06%. Reduction in brain volume loss was 0.19%, or less annually in years 3 through 8. The safety profile in year 8 was consistent with the previous years. The incidence of adverse events, infections, and thyroid adverse events continued to decline through year 8. Moving on to the data from TOPAZ from the cohort of patients who were treated with subcutaneous interferon beta-1a over the 2-year CARE-MS2 core study. Of 143 patients initiating alemtuzumab in the extension, 117 completed year 2 of TOPAZ, 6 years after initiating alemtuzumab. 57% received neither additional courses of alemtuzumab nor another DMT through year 6. At year 6, the annualized relapse rate was 0.19, and 68% of patients had stable or improved EDSS scores from CARE-MS2 baseline. After initiating alemtuzumab, 69% were free from 6-month confirmed disability worsening, and 23% had 6-month confirmed disability improvement. At year 6, 89% were free of new enhancing lesions, 69% were free of new or enlarging T2 hyperintense lesions. Median percent cumulative brain volume loss from CARE-MS2 baseline was minus 1.34% over 8 total study years. Minus 0.81% occurred over years 0 to 2 with subcutaneous beta interferon 1a, and negative 0.53% occurred over 6 years with alemtuzumab. Safety was consistent with the alemtuzumab arm of the core and extension study. Additional data from the core, CARE-MS, extension, and TOPAZ studies showed in patients with disease activity after the initial 2 courses, a 3rd course of alemtuzumab, given on the average of 2.5 years after course 2, improved clinical and MRI outcomes up to 36 months. Safety was similar to the overall CARE-MS population and those receiving 2 courses over 7 years. In the small percentage of patients with disease activity after retreatment, a 4th course of alemtuzumab, given on the average 1.9 years after course 3, improved clinical and MRI outcomes up to 36 months, with safety being similar to the overall CARE-MS population and those receiving 2 courses over 7 years. In addition, efficacy of alemtuzumab on clinical MRI brain volume loss outcomes was maintained over 7 years in relapsing remitting MS patients of African descent. Now let's shift our focus to ocrelizumab. The OPERA-1 and OPERA-2 trials compared ocrelizumab with subcutaneous interferon beta-1a in patients with relapsing MS. Following completion of the double-blind controlled treatment phases of OPERA-1 and OPERA-2 studies, patients were eligible to enter the open-label extension phase to evaluate the long-term safety, tolerability, and efficacy of ocrelizumab in relapsing MS. Data from this open-label extension were presented at the 34th Congress of ECTRIMS. Overall, 88.6% of patients who entered the open-label extension of the OPERA studies completed year 3 of the extension. switching from interferon beta-1a to ocrelizumab at the start of the open-label extension period was associated with a rapid and robust reduction in annualized relapse rate, which was maintained through year 3 of the open-label extension period. The benefits of ocrelizumab on annualized relapse rate and 24-week confirmed disability progression, as seen in the 2-year double-blind controlled period, were maintained after 3 years in the open-label extension period. The treatment benefits seen with ocrelizumab in the oratorio open-label extension was consistent with that seen in the double-blind period and was maintained across different time points. After 5.5 years of follow-up, disability progression outcomes favored those on early and continuous treatment with ocrelizumab compared with delayed initiation. Disability progression in EDSS, a 9-hole peg test, was lower in patients who initiated ocrelizumab treatment earlier, ocrelizumab to ocrelizumab group, compared to patients initially receiving placebo to ocrelizumab group. Patients initiating ocrelizumab between 3 to 5 years earlier accrued significant and sustained reductions in disability progression, compared with patients switching from placebo. The significant and clinically meaningful benefit in reducing disability progression by ocrelizumab in patients with primary progressive MS in the oratorio study is durable, with up to 5.5 years of follow-up. Updated data on the safety of ocrelizumab showed the reported rates of adverse events per 100 patient years in the ocrelizumab MS all-exposure population continue to be generally consistent with those seen during the controlled treatment period in the relapsing MS and primary progressive MS populations. In the ocrelizumab all-exposure population, the rate per 100 patient years of serious infections increases over time with no change in the type or pattern of serious infections observed. 2 serious opportunistic infections have been confirmed in patients with ocrelizumab clinical trials as of February 2018. In the updated exposure period to February 2018, the rates of malignancies in ocrelizumab-treated patients remain within the range reported in epidemiologic data. Long-term follow-up and post-marketing requirement studies will monitor safety over time in patients with MS receiving ocrelizumab, including identified and potential risk. The Phase 3b CORD study enrolled a population of patients with relapsing remitting MS relatively early in their disease course, most of whom initiated ocrelizumab after suboptimal response to a single DMT, primarily Glatiramer acetate and dimethyl fumarate. Findings from an interim analysis of the first 153 patients completing 1 year of follow-up presented at ECTRIMS 2018 included: the majority of patients had no protocol-defined relapse, no T1 gadolinium-enhancing lesions, no new or enlarging T2 lesions, and no 24-week confirmed disability progression. Furthermore, 58.9% of patients were free of any of these protocol-defined events. In addition, safety observations to date were consistent with the known overall safety profile of ocrelizumab. Updates of the monoclonal antibodies at ECTRIMS was very important to our own clinical practices. One of the exciting things to see is the long-term data looking at JC virus antibody status, which becomes very important in clinical management of our patients with MS. In addition, we saw significant impacts on brain volume loss by alemtuzumab. And in the CARE-MS2 trial, we saw that loss of brain volume was only 1.06% loss over 8 years, which is in the range of normal brain volume tissue loss. In addition, we saw the impact of ocrelizumab. On primary progressive MS, we saw at 5.5 years that it slowed down the progression of disability in those started early with treatment with ocrelizumab versus those initially on placebo. And we also saw great data in the patients switching from interferon onto ocrelizumab and extension had robust impacts on annualized relapse rate and on MRI activity. Finally, let's briefly review some new data on emerging therapies that were presented at 34th Congress of ECTRIMS. Ozanimod is an oral selective sphingosine 1-phosphate receptor modulator in development for relapsing MS. Updates from the results of the Phase 3 Radiance, Part B, and Sunbeam trials, which compared ozanimod with intramuscular interferon beta-1a, were presented in Berlin. For example, an analysis presented by Comey and colleagues showed ozanimod treatment resulted in a lower annualized relapse rate and MRI activity versus interferon in patients with early relapsing MS, with similar effects seen in patients with more advanced disease. Another analysis showed ozanimod reduced rates of annualized relapse rate requiring steroids or hospitalization versus interferon beta-1a. Another poster showed that confirmed cases of macular edema were observed in ozanimod-treated patients at a low rate and similar to the incidence reported for placebo in other S1P studies. The effect was not dose-dependent. Lastly, a pooled safety analysis showed there were no cases of ozanimod-related symptomatic reduction in heart rate and no occurrences of second-degree or higher AV block observed at the time of first dose, during dose escalation, and during chronic dosing. Siponimod is another S1P receptor modulator that is under investigation for the treatment of secondary progressive MS. At the 34th ECTRIMS Congress, Capos and colleagues present the results of a pooled analysis of the BOLD and EXPAND trials, which evaluated the long-term safety of siponimod. Long-term treatment with siponimod 2 milligrams revealed no increased rates of adverse effects or new safety findings versus the control population. In addition, low lymphocyte counts were not associated with an increased infection rate. Now let's turn our attention to oral cladribine. The efficacy of cladribine tablets, 3.5 milligrams per kilogram, cumulative dose given in short courses annually for 2 years, has been demonstrated in patients with early MS in the Oracle MS study and in patients with relapsing remitting MS in the Clarity study that was maintained in the Clarity extension study. The most common adverse event in Clarity and its extension was lymphopenia. A large number of posters on cladribine was recently presented at the 34th Congress of ECTRIMS. For example, a post-hoc analysis of Clarity extension showed the long-term clinical effect was sustained in patients with high disease activity who were treated with cladribine tablets 3.5 milligrams per kilogram in Clarity. In addition, an exploratory analysis of Clarity, cladribine tablets 3.5 mg per kg, was efficacious in patients both above and below 45 years of age with respect to reduction in relapse frequency and the number of MRI lesions consistent with previous similar analysis. Moreover, an integrated analysis of Clarity, Clarity Extension, Oracle MS trials, and the Premier Registry confirmed the serious treatment-emergent adverse effect profile associated with cladribine 3.5 milligram per kilogram in patients with early and active relapsing MS. The updated profile, cumulative to May 2017, was generally consistent with that from 2 years prior, cumulative to February 2015. No new major safety findings were identified in the updated dataset, where patients were followed for up to 10 years. And finally, let's discuss evobrutinib, which is a highly specific oral inhibitor of Bruton's tyrosine kinase, BTK, that functionally impairs activation of B cells and macrophages in vivo and may be effective in autoimmune disease. At the 34th Congress of ECTRIMS, Montalban and colleagues presented the results of a phase 2 study evaluating evobrutinib in patients with MS. In this double-blind, placebo-controlled 48-week phase 2 study, patients aged 18 to 65 years with relapsing remitting MS or secondary progressive MS with superimposed relapses were randomized to evobrutinib 25 milligrams once daily, 75 milligrams once daily, 75 milligrams twice daily, placebo, or open-label dimethyl fumarate, the reference arm. The primary endpoint of this study was the sum of T1 gadolinium-enhancing lesions at weeks 12, 16, 20, and 24. Key secondary endpoints included annualized relapse rate at week 24 and safety. The primary endpoint was met, with evobrutinib 75 milligrams once daily and 75 milligrams twice daily, significantly reducing the number of T1 gadolinium-enhancing lesions versus placebo. In this 24-week analysis, evobrutinib led to numerical and clinically relevant decreases in annualized relapse rate, with evidence of a dose response. Safety profile was notable for hepatotoxicity events. These data support a role for evobrutinib in MS, warranting evaluation in larger trials. It's an exciting time in MS. After attending ECTRIMS in Berlin, a lot of new data was presented that it's going to impact how we clinically treat patients in the future. We do have new oral agents coming. Cladribine data was presented. And the exciting thing is we can see the extension data and how cladribine has had very good safety data as we go forward. We've saw from the pivotal trials the impact of cladribine, including Clarity trial, on annualized relapse rate. In addition, we have some new data on S1P molecules. So S1P, one of the S1P modulators is siponimod, and siponimod was effective in secondary progressive MS and may have a direct role in treatment for secondary progressive patients, which is an unmet need. We also saw data on ozanimod. One of the interesting data points that we saw for ozanimod is lack of second-degree heart block with initiation of ozanimod, another S1P inhibitor useful in relapsing forms of MS. In addition, BTK inhibitors, such as evobrutinib, may be an oral option for the treatment for relapsing forms of MS. So it's an exciting time with a lot of potential future options available, with the main goal of trying to control our patients with relapsing, primary progressive, and secondary progressive MS. Recently presented data continue to add to our breadth of knowledge on the efficacy and safety of conventional injectable DMTs for relapsing MS. New analysis of recent clinical trials and their extension studies provide new insight into the long-term efficacy and safety of approved oral disease-modifying therapies. Late-breaking data on approved monoclonal antibodies provide additional understanding in the potential benefits of these therapies with respect to their effectiveness in early disease, durable efficacy, and safety in patients with MS. There are also a number of emerging disease-modifying therapies in various stages of development for the treatment of either relapsing or progressive forms of MS. It has not yet been determined how these potential advances might fit into the current treatment landscape. That ends our discussion for today. I hope you found it informative and useful for your practice. I encourage you to download the slides and practice aids from this activity, which includes summaries of additional data not discussed during this program.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/YBU. This activity is supported by educational grants from Biogen and Sanofi Genzyme.